Hi everyone, I am Dr.Jamuna Rani MD Pathology. I am working as Professor, Department of Pathology, Tagore Medical College and Hospital, Chennai. I am glad to meet the medical students across India through the All India Medical Students Association. I thank the organizers of the Tamil Nadu chapter of All India Medical Students Association for inviting me for today's topic, Thalassemia. Today is May 8, 2020, World Thalassemia Day. This day is celebrated across the world every year to commemorate people with thalassemia and enable them to have a quality of life. So the objectives of my session would be to understand the etiopathogenesis of thalassemia and correlate with the clinical features, to understand the laboratory diagnosis, prenatal diagnosis and genetic counseling of thalassemia, finally a note on the management and prevention of thalassemia. So we all know that the role of hemoglobin would be to carry the oxygen and carbon dioxide between the tissues and the lungs. Hemoglobin, a 64,500 Dalton molecule which is composed of heme and globin. There are different types of hemoglobin, the most common and the most important being hemoglobin A, also known as adult hemoglobin, hemoglobin A2 and hemoglobin F, also known as the fetal hemoglobin. The various percentages of the hemoglobin in an adult would be hemoglobin A 97%, hemoglobin A2 2.5% and hemoglobin F 0.5%. The adult hemoglobin has two subunits, alpha 2 and beta 2. So having understood the basics of hemoglobin, let's look into thalassemia. So thalassemia is an inherited heterogeneous disorder which is characterized by the complete absence or reduced synthesis of one of the globin chains. So accordingly, there are many types of thalassemia, the most common being beta thalassemia and alpha thalassemia. Beta thalassemia, where there is a complete absence or reduced synthesis of beta chains, and alpha thalassemia, which is characterized by the complete absence or reduced synthesis of alpha chains. Further, thalassemia is classified based on the disease severity and molecular genetics. For example, beta thalassemia is classified into three types as beta thalassemia major, beta thalassemia intermedia and beta thalassemia minor. The beta chains are coded by two sets of genes located on chromosome 11. Beta thalassemia major would be either beta 0, where both the beta genes are completely lacking the synthesis of beta chains, or beta plus, where both the beta genes are producing beta chains but at a reduced level, or can be beta 0, beta plus. Next is beta thalassemia intermedia, where it is again beta 0, beta plus. It means one globin gene is not producing any of the beta chains and other gene is producing a reduced quantity but not that much reduced to cause a beta thalassemia major. So the severity is very less and we categorize as beta thalassemia intermedia. Similarly, beta thalassemia minor, it is beta 0, beta or beta plus and beta. Beta thalassemia major or all transfusion dependent thalassemia, that is TDT, whereas beta thalassemia intermedia will not need transfusion. It means they will occasionally need transfusion. They will not be totally dependent on transfusion. So they are called that is NTDT, that is non-transfusion dependent thalassemia. And beta thalassemia minor would be an asymptomatic or a mild thalassemia and they will usually be carriers of this thalassemia. Now we'll move on to alpha thalassemia. So alpha thalassemia is coded by four set of genes located on chromosome 16. So accordingly, there are four types of alpha thalassemia. The most severe form would be hydrops fetalis, where all the four genes are completely not producing the alpha chains, and hemoglobin H, where the three genes are not producing alpha chains and only one alpha chain is there. Alpha thalassemia trait, where two alpha chains are not there either from the same chromosome or one from each chromosome. The fourth type would be the silent carrier, where three alpha chains are there and one is not there. The severe form hydrops fetalis will cause an intrauterine fetal death. So for these people, if there is a prenatal diagnosis done, they should have an intrauterine transfusion and after birth they have to have a hematopoietic stem cell transplantation. Hemoglobin H disease would have a severe thalassemia. The alpha thalassemia trait will be asymptomatic, but the peripheral smear will show microcytic hypochromic RBCs. And the fourth type, being the silent carrier, will be asymptomatic with the normal RBC morphology. Hence, the detection of the silent carrier is really very tricky because prenatal diagnosis depends on detection of the silent carrier. Having seen the etiology, now let's look into the pathogenesis and correlate the pathogenesis with the clinical features of thalassemia. So beta thalassemia. So beta thalassemia is because of the defect in the beta globin chain. So that is mainly because of mutations involving RNA splicing, mutations in the promoter region and chain terminator regions. Because of the defect in the beta chains, there is a reduced beta chains, so there is a excess alpha chain. So there is a reduction in the hemoglobin. So because of the reduction in the hemoglobin, the RBCs are all very small, causing microcytic hypochromic red cells. And this excess alpha chains, so they are all insoluble, they accumulate in the RBC, causing a RBC membrane damage. So these RBCs with the damaged membrane will undergo apoptosis and ineffective erythropoiesis. So these microcytic hypochromic red cells will have a target cell because this insoluble alpha chains are accumulating within the red cells. So this is the appearance, and here we can see the target cells. And because of the reduced hemoglobin, thalassemic people will be anemic since birth. Because of anemia, there is always a tissue hypoxia, and so thalassemic children will have a developmental delay, and this anemia further causes a extramedullary hematopoiesis and erythroid hypoplasia. So this extramedullary hematopoiesis will have a crooked appearance or a hair-on end appearance in the skull. So in the X-ray we can see this typical picture of crooked appearance. So let's again look here. So because these target cells are there in the blood smear, so they are all damaged in the spleen, causing an extravascular hemolysis. Because the spleen is doing this extravascular hemolysis, there is always a splenomegaly in thalassemic people. So because of apoptosis and ineffective erythropoiesis, the need for iron in thalassemic is very high, because to produce more erythroid precursors there is a need for iron. So the body tends to absorb lot of iron. So there is an increased iron absorption. Another reason for iron absorption is anemia. So because of anemia there is an increased erythropoietin production, which also acts as a signal to increase the iron absorption. So because of the increased iron absorption, there is an iron overload in thalassemic people. So these people will have a secondary hemochromatosis involving the liver and the heart. So there is a hepatomegaly in thalassemic people. Another reason for hepatomegaly would be a reduced hemoglobin. So that is causing an extramedullary hematopoiesis, causing a hepatosplenomegaly. Another problem with anemia is that this thalassemic people, because of anemia, they are always dependent on blood transfusions. So they are prone to multiple transfusions, and hence they have lot of risk for transfusion transmitted infections. So this multiple transfusion also causes a iron overload in thalassemic people. So a thalassemic people will have a developmental delay with a hair on end appearance in the X-ray. They are prone for complications of splenomegaly, iron overload and transfusion transmitted infections. Because of extravascular hemolysis, they also have a jaundice. The diagnosis of thalassemia is based on clinical examination, family history and relevant laboratory investigations. The peripheral smear in a thalassemia will have microcytic hypochromic red blood cells, target cells, polychromasia, nucleated red cells and basophilic stippling. The RBCs will show anisopoikilocytosis, that is variation in the size and shape of the red blood cells. The bone marrow will have a erythroid hypoplasia. Reticulocyte count will be elevated, but it will be less compared to the severity of anemia because of ineffective erythropoiesis. The diagnosis of thalassemia is based on hemoglobin electrophoresis and high performance liquid chromatography. However, to detect carriers and prenatal testing, we have to do a DNA analysis and identify the mutations in thalassemia. Prenatal testing can be done with amniocentesis or chorionic villus sampling. The treatment of thalassemia. Treatment involves multiple blood transfusions as and when needed and iron chelation therapy. The only cure for thalassemia that is available as of date will be allogenic hematopoietic stem cell transplantation. However, the limitations of allogenic hematopoietic stem cell transplantation would be availability of the donors, graft versus host disease, and mainly the cost of the stem cell transplantation. So the best strategy which is available till now for thalassemia would be prevention of thalassemia. The World Thalassemia Federation, which is officially related to WHO, has nearly 232 members working across 62 countries in the globe. Is taking care of people with thalassemia. They focus on health education for thalassemia, emphasizing mainly on the economic burden and career screening. So today, May 8th, 2020, as medical professionals, let's all pledge to eliminate thalassemia from the country by career screening and also support thalassemic people by giving them a quality of life that everyone in the world deserves to. Thank you.